Welcome, everyone. It's a pleasure to have you here on our PARC Speakers series. Today, it's an honor and a pleasure for me to introduce my good friend and colleague, Dr. Judah Koller, who is joining us from Israel. I have known Judah for many, many years now. We first met when he was a postdoctoral fellow at Yale University in the US. And from the first time I met Judah, I was impressed by his genuine care and interest in helping autistic children, youth, and families. And we have kept in touch throughout the years and have been colleagues and good friends and collaborators as we share the same vision for autistic children, youth, and their families. So Judah is an assistant professor of clinical child psychology and special education at the Seymour Fox School of Education at Hebrew University, where he directs the Autism Child and Family Lab. Judah is also director of the Jerusalem region of the Israeli National Center for Autism and Neurodevelopment Research, and serves on various local and national committees, including the Israel Ministry of Health's Interministerial Expert Committee on Autism. Above all, for me, Judah is one of the most influential clinician scientists in the autism community globally, and I'm really pleased to have him with us today for a talk called Family Accommodations in Autism, zooming in on the complexity of restricted and repetitive behaviors. Thank you, Judah, for being here, and the floor is yours.
Thank you so much, Stelios, and thank you, Anna. Stelios, that introduction was overly kind. I think you might have oversold it, but I will do my best. And it is really a true pleasure and privilege to be here speaking with you today. I will come back in a couple of minutes to mine and Stelios's first meeting in New Haven. Before I dive into the topic, I want to acknowledge the trying times that my part of the world is experiencing right now. I want to acknowledge the tremendous loss of life and the ongoing tragedy of the situation. And I want to say that engagement in projects like PARC, focused on deepening our understanding and our ability to support children and families, provides strength to me, to my team, and it provides inspiration that perhaps better times are ahead. So it is really, it is humbling to be part of this project, and I'm very grateful for the opportunity. In our time together this morning, we're going to try to accomplish a number of different things. The first thing we're going to do is together open up the DSM, the so-called Bible of Psychiatry, and re-examine what it actually means to be autistic according to the DSM. I'll then go into some core challenges that exist both in research and clinical contexts, specifically regarding the second criterion within the DSM, that of restricted and repetitive behaviors. I'll talk about a new idea that we've been thinking about and studying for several years in the context of our lab that we hope bears potential to help us understand and support autistic children. And then I'll talk about a couple of the projects that are running in the lab that hopefully are helping us move forward in that direction. Before I do that, I want to, for a moment, talk about my own professional developmental trajectory, because it's somewhat atypical for academia and very much influences how I think in the work that we do. So I did my doctorate at Yeshiva University at Furcaf Graduate School for Psychology in New York, my pre-doctoral internship at the New York Center for Child Development, which is an early intervention provider in the city of New York. So it provides public early intervention services to children with developmental delays, both diagnostic and intervention, specifically in East Harlem and in the Bronx. I then, as Stelios mentioned, had the good fortune to do my postdoc at the Child Study Center at Yale. In 2013, I returned to Israel, and I was involved for a number of years in establishing the Autism Center at Hebrew University. And then about 4 years ago, I became fully focused on my own research and established the Autism Child and Family Lab here within the School of Education. Yale was a wonderful place, but it was mostly worth going there because of a specific encounter that I had with a young and upcoming researcher named Stelios Georgiadis, who visited us to give a talk at the Child Study Center. And there's a famous hamburger that we went out and shared. And that was the first thing that was shared. But as Stelios mentioned, although I think he got it backwards, the privilege has truly been mine. And I am honored to call Stelios both a collaborator, a colleague, and a friend. Beyond sharing the burger, we've shared a number of other things over the last several years. One of them is a very modest paper that we wrote, that we published, sort of an editorial. And you will see the expression of the thoughts that are contained in that paper over the course of our time together this morning. I want to first acknowledge my lab. So our lab is very good at many things. We're not apparently very good at taking group pictures. So these are our multiple attempts over the last several months to get everyone in one picture. I'm happy to share the credit both for the research that we do, but also for the thoughts that I have and the conceptualization that I'm going to offer with the students in my lab, and obviously with key collaborators. But I'm also happy to share the criticism with them. And so, although none of them are with us on this Zoom now, if there's anything that you like less about the talk, let me know, and I'm happy to direct you to relevant lab members. Okay, so let's together open up the DSM and let's read it. We're not zooming in all the way, but let's see what we need to prove if we want to determine that an individual, in our case, a young child, is autistic. Which reminds me to mention, as Anna mentioned, that I will be using identity-first language in the course of this talk, based both on research that's been done and conversations that I've had with colleagues and friends who are themselves autistic and who prefer this language. So the DSM tells us that to formally identify an individual as autistic, I need to prove a number of things. The first thing I need to prove is that this individual struggles. There is some sort of impairment regarding their social communication and interaction. I also need to prove the presence of what we call restricted and repetitive behaviors and or stereotyped interests. Over the course of the next 40 or so minutes, I'll be using the term RRBs because it'll save us time. These are the two primary diagnostic criteria, although they're not classified as such in the DSM. And these are the criteria that most people think of and are aware of when we talk about diagnosing autism. But the DSM goes on. So criterion C in the DSM forces me as a clinician to prove that these symptoms included in A and B are present in early childhood, but parenthetically, may not manifest until social demands exceed capacities. And we continue. Criterion D says that whatever symptoms I may have just checked in my evaluation, I only have a right to leave them checked if those symptoms don't only characterize the individual, not only are they present, but they must cause clinically significant impairment in social, occupational, or other areas of functioning. Meaning, the fact that these symptoms, these behaviors, these characteristics or traits exist must make this individual's life harder. And if they don't, I must uncheck that symptom according to the DSM. Now, the lion's share of research in the field of autism focuses on criterion A, impairment in social communication and interaction. We today are going to talk about what our lab mostly focuses on, and that is criterion B, the RRBs. I will only repeat myself, and I'll do this a couple more times over the course of our time together, and say that these symptoms are only diagnostic if they cause impairment in functioning. When we zoom out from the DSM, we might be fooled into thinking that this diagnostic category is neat and orderly and well-defined and unitary, while in fact we know that that's not the case. For within this category, we know that there is tremendous heterogeneity. We have autistic individuals with an IQ of 40, and we have autistic individuals with an IQ of 140. We have autistic individuals who do not understand that they, as individuals, contain within themselves the capacity to communicate with other people. And we have other autistic individuals who engage in incessant communication through language and otherwise. And this is what is behind the already cliche statement in our field: if you know one autistic person, you know one autistic person. I would argue that there should be a continuation to that statement. And that is that if you know one thing about one autistic person, you know one thing about that autistic person. Because to go back to the two developmental domains that we just mentioned, we know that there is a subset of autistic individuals with average or above average intelligence who do not have the capacity to communicate using spoken language. So the correlation between any two of these domains is not necessarily strong or present to any degree. This heterogeneity exists when we focus only on criterion B as well. Here too, we might be fooled into thinking that RRBs are a nice and neat symptom category, while in fact we know that within this symptom group, there is tremendous heterogeneity. We have motor behaviors such as repetitive motor movements. We have repetitive language. We have more cognitive characteristics such as highly intense and fixed interests. There have been multiple attempts over the past 20 years to deal with this heterogeneity within RRBs. It started out by a distinction between what we call lower order and higher order RRBs, which are synonymous with motor behaviors as lower order behaviors, and things like insistence on sameness, which are more cognitive traits, which is synonymous with higher order behaviors. There have been more nuanced attempts to distinguish between subgroups of RRBs, things like self-injurious behavior, restricted, ritualistic, sameness behavior. This is something that the field continues to struggle with. I will just remind us that any symptom within this group is only relevant to our conversation if it causes impairment in social, occupational, or another area of functioning. This notion of heterogeneity plays a little bit differently when it comes time to talking about early autism intervention. Here, a family of a newly diagnosed child might get lost in Google when searching for evidence-based or best practice interventions for young autistic children. They may see things like Jasper, Floor Time, Denver, PRT. I'll specifically highlight the wonderful social ABCs model, which we've had the opportunity to work on together with Jessica Bryan and her team. And there are significant differences between these models and between these approaches. There are differences in the techniques. There are differences in methodologies. There are differences in measurement. There are absolutely distinctions between these different models. But there are also significant similarities. Most evidence-supported early intervention approaches for autistic children now reside within what we call the NDBI world. They are naturalistic in that they take into account the day-to-day life. They must make sense within the context of the day-to-day life of these children. They are developmental, so they make sense in the context of the specific developmental profile of this child. They are behavioral in that they acknowledge that if we change what comes prior to and following a behavior, we are likely to impact that behavior. And they are structured in that we don't get into the room and act without having a plan, without knowing what we are trying to accomplish and how we are hoping to accomplish it. Another thing that nearly all autism interventions have in common is something that is missing. Not that they don't take it into account, but something that is missing in terms of targets within the intervention. There is a nearly complete absence of interventions which target criterion B, which target the RRBs. And so I would ask, why is that the case? Why do we see nearly no acknowledgement of RRBs as intervention targets when in principle, they represent half of the physical expression of this syndrome? I would posit that there are two key challenges behind this absence. The first challenge is that of measurement. We have two ways today, by and large, to measure RRBs. The first is through semi-structured assessment, such as the ADOS, which we rely on, we use day in, day out in our lab. The ADOS is a wonderful and important essential tool in the autism diagnosis world. It is challenged in that it generates one or two specific scores that are intended to capture the heterogeneity within RRBs. And like anything that happens in the clinic or in the lab, it is not necessarily representative of reality. A child can engage in A and B and C prior to coming into the room and being administered the ADOS. And if while they are in the room, they only show us Q and R and Z, that A and B and C do not make it into the ADOS scores. The second option for measuring RRBs today are parent report measures. Here we have semi-structured interviews such as the ADI, or self-report parent report measures regarding RRBs such as the RBSR. These are also essential tools in our attempt both to study and to understand autistic children. They are challenged by reporter bias because we are depending on what the world looks like through the eyes of the person filling out or responding to the measure. And they are time limited because all of these measures ask parents or caregivers or teachers to relate to the child's RRBs over the last week or 2 weeks or month. And anything that happened prior is not considered in that context, and certainly, obviously, anything that happens afterwards. Our ability to measure RRBs is further challenged because we know that RRBs vary across contexts and across development. In fact, the DSM acknowledges that in what we read earlier. The DSM tells us in those parentheses in criterion C that symptoms may not become fully manifest. We may not see a symptom until the demands of an environment exceed capacities, meaning that we may not see a symptom until the challenges are greater than the capacity or the abilities of the child. This means that if I ask a parent or a preschool teacher to report on a given child's symptomatology, let's take RRBs, and that individual knows the child in a certain context where, let's say, the demands do exceed the capacity, because it is not an environment that is adapted for neurodiverse children, they will report high levels of symptomatology and significant expression of RRBs. Whereas if I ask another individual to report on the RRBs of another child with a very similar profile, but they know that child within a context that is adapted and modified and appropriate for neurodiverse children, and the demands do not exceed capacity, they will report on a much lower level of symptom expression and perhaps far fewer RRBs. The second key challenge I would like to highlight is our inability to determine between RRBs that are adaptive and maladaptive. Other than self-injurious behaviors, if you tell me a child is engaging in repetitive motor behavior, or a child displays a restricted interest, or other stereotypies, I will not know how to tell you whether or not that RRB is adaptive or maladaptive. It could be that this fixation, this behavior, this interest is precluding the child from learning, from maximizing their exposure to an educational environment. However, at the same time, it could be that this behavior or this interest is the very thing that is enabling this child to learn and to maximize their ability to take in information from their environment. Which is why before considering any RRB a target in intervention, we must proceed extremely cautiously and take into account that specific RRB within the context of that specific child's broader characteristics, their family dynamics and home environment, their classroom environment, and perhaps their community. And only when we consider a specific behavior within those broader contexts might we be able to determine that this given RRB is or is not worthy of intervention. This is further challenged by the fact that we know that RRBs vary across contexts and development, and that what starts out adaptive at a given point in time may become maladaptive with time. For instance, echolalia. There are young children who are neurotypical and typically developing who learn language through echolalia, and that is normative. But if that child's communication continues to stay within the realm of echolalia as time goes on, then that would be considered at some point maladaptive. To sum up what we just said, the absence of RRBs in the intervention literature is likely attributable, at least in part, to two key challenges. The first of measurement, our ability to measure these symptoms accurately and in a way that represents reality. And the second is our inability to determine for any given child which RRBs are adaptive and which are maladaptive. This is something that we've been thinking about for years in the lab, and we are working on what we consider a partial solution that I will describe to you in a few minutes. This partial solution rests on a notion called family accommodation. Family accommodation is an idea that comes not from the autism world, but from the world of OCD and anxiety, as I will describe in a moment. And it refers to ways in which parents modify their behavior to help a child avoid or reduce distress that stems from a psychopathology, an impairment, or a difference. This notion has been researched at length in the context of children and adolescents with OCD and anxiety, where it has been shown clearly that families that engage in more accommodation are likely to have children with increased severity of symptoms, lower psychosocial functioning, and poorer response to intervention. We understand the mechanism in the context of OCD and anxiety, wherein the accommodation is part of an endless cycle of anxiety reduction and increase. We know that there is a partial diagnostic and phenotypic overlap between autism and OCD, meaning that part of the symptoms of these two diagnostic categories overlap with each other. And this too is expressed in the DSM itself. When we open the DSM and we read what RRBs are, they are defined as restricted, repetitive patterns of behavior, interests, or activities. When we look at the definition of compulsions within OCD, we see that they are defined as repetitive behaviors or mental acts. So these are not synonymous, but they certainly bear resemblance to each other. And this resemblance is what set me, along with colleagues, and there you see Eli Leibowitz in the corner, and Professor Ditsa Zachor next to him, off on a research journey a number of years ago to try to understand whether or not parents of autistic children accommodate their children's RRBs. So do they act in a way that is intended to reduce their children's stress that comes from the RRBs? And if so, is there any clinical significance to it in the context of autism? Ellie is a partner at every step of the way within this process. Ditsa was essential in helping us begin this exploration. In our initial study, which was published a number of years ago at this point, we found that over 60% of parents of autistic children engage in accommodation on a daily basis, that around half of these parents report that these accommodations cause them distress, and that 60% of them told us that when they do not engage in accommodation, their children respond aggressively. Perhaps most significantly, and remember that this is a cross-sectional study, so we are not talking about what causes what, only that these two constructs seem to be linked. Families that engaged in higher levels of family accommodation were likely to have children with much higher levels of RRB symptom severity. This initial study also allowed us to begin to understand what this accommodation might actually look like in the context of autism. So a couple of examples from our early study. Child who gets upset when his bed and room are not neatly arranged in a very specific fashion when he comes home from school is accommodated by parents who drop the child off at school and then, instead of going to work and arriving on time, come home and take the 15 or 20 minutes every day to arrange the room just so. A girl who must have a specific type of cookie in her hand every time she leaves the home is accommodated by parents who make sure that they will drive to every supermarket in the city to find those cookies, and they place the cookies in a cookie jar immediately next to the door in order to avoid any dysregulation on the part of the child. In another study, we looked at the presence and significance of family accommodation in the context of autistic children with disruptive behavior. And there we found that more than autism symptomatology, parenting stress, or adaptive functioning, the disruptive behavior of these children was most closely linked with the level of family accommodation that the parents engaged in. This brings me to SPACE. SPACE is an evidence-based parent-mediated intervention developed by Ellie Leibowitz, which specifically targets anxiety through the systematic reduction of family accommodation. Children are not active participants in this intervention. It is only the parents who are asked to modify their behavior, and it has been found to be extremely effective, equal to the effects of standard CBT in the context of anxiety and OCD. A few years ago, working with Ellie and with Dr. Yaira Shimshoni, but this project was led by wonderful PhD student Shir Rosenblatt, along with the essential help of her dog Johnny there. We took the SPACE protocol, we made a few small modifications, and we attempted to see whether it would be helpful, feasible, and effective for us in helping parents of autistic children reduce anxiety in the context of autistic children and anxiety. And we did this because we wanted to know, in this journey of ours, to better understand the presence and significance of family accommodation in autism, whether or not the notion of using family accommodation as a port of entry to supporting autistic children was even reasonable to presume. So this paper also came out a year or two ago. This was a small pilot study. Families reported that it was a positive experience for them, I think mostly because Shir is wonderful. And cherry picking from the findings, we found that utilizing SPACE, so asking parents to reduce their accommodation of anxiety in the context of children with comorbid autism and anxiety, led to a reduction in anxiety at the end of the intervention that maintained a few months afterwards, and a concurrent reduction in family accommodation behavior that similarly maintained. This graph allows us to look at the individual trajectories of anxiety symptoms in the children that participate in the study. What was particularly exciting for us to see is that the vast majority of participating children ended the study below the clinical cutoff for anxiety. So to summarize what we've learned so far, we know that parents of autistic children tend to accommodate their children's RRBs. We know, although I did not say, that this accommodation associates with increased RRB severity, and we also saw in that same sample that it associates with lower adaptive functioning, such that families who engage in more accommodation have children with higher symptom severity and more support needs. We know that for autistic children with disruptive behavior, this accommodation associates with parenting stress and disruptive behavior, and that family accommodation of anxiety in co-occurring autism and anxiety is malleable, and that reducing it can improve symptomatology. I'm going to transition now to talk about some of the work that we're doing currently to continue moving forward with this line of research. The first thing that we understood was essential to do was to take a developmental perspective. Those initial studies were on older, more heterogeneous samples. And so we are currently looking at family accommodation or at accommodation of RRBs in early childhood across time, taking into account both parents when relevant, as well as teachers, preschool teachers. We also are attempting to grapple with the challenge of measurement. And all of this, we consider a stepping stone to thinking about support and considering whether or not family accommodation may serve as an effective mechanism of support for improving the well-being and quality of life of autistic children. I'll start out with the developmental perspective. Before I get to the what, I want to speak for a moment about the how. A couple of years ago, we established in our lab at Hebrew University an evaluation infrastructure, which is open to the public. It's no cost to families, where we conduct developmental and diagnostic evaluations for young children between the ages of 2 and 4 years old. These evaluations are conducted in English, Hebrew, Russian, and Arabic. Families come in for a gold standard evaluation, fill out approximately 7,412 questionnaires. 6 months later, they fill out those questionnaires again, And 6 months after that, so a year after the initial visit to the lab, families come back and we do it all again. Beyond allowing us to look at constructs like family accommodation, this infrastructure also allows us to engage in other essential developmental work. And here I'm proud to say, as was mentioned earlier on, that we recently are officially joined the International PARC project, having received funding from the Azrieli Foundation. And the families recruited to PARC in the context of our lab and in Israel will be recruited within the context of the evaluation infrastructure that exists in our lab. We use this infrastructure to look at the presence and significance of accommodation in young children. So to date, I can report not on longitudinal studies, but at a single time point, looking at both parent and teacher accommodation of RRBs among young autistic children. And this is work led by Tamar Matz-Weissman, another wonderful PhD student. So in terms of the presence of accommodation, here you see that mothers and fathers and teachers engage in approximately between 45 to 60% of these individuals engage in accommodation on a daily basis, and on a weekly basis, much more so. So it's something that exists. When we looked at the relationship between accommodation behaviors reported on by mothers and fathers, we saw that they were closely linked to each other. So when one parent engages in accommodation, it is likely that the other parent is engaging in accommodation as well. When we looked only at mothers, we saw that her accommodation associated with a decrease in adaptive functioning, so more accommodation indicated more support needs, and higher symptom severity in the area of RRBs. When we looked at fathers, we saw that similarly, more accommodation on the part of fathers associated with higher symptom severity in the form of RRBs, but there did not appear to be a relationship between father's accommodation and child's support needs. We then went on to look at teachers, and we found something which I think is fascinating and certainly warrants further investigation. Even more than parents, we found very, very high levels of reported accommodation behavior on a daily basis, but no apparent connection between that accommodation, RRB expression, or adaptive functioning. I will say that that is likely because we have different reporters for these different measures. So the preschool teachers are reporting on their accommodation, while for the measures of RRB and adaptive functioning, we are relying on parent reports. So this is something that we are looking at more closely today, aiming to collect data from teachers on their reporting of RRBs and functioning. The second thing I mentioned that we're focusing on now is the challenge of measurement. And I had mentioned earlier that the two approaches we have today are semi-structured assessments and parent report measures, each with their strengths and their vulnerabilities. Below you see Shir again and Johnny. To her left, you see Professor Mor Nahum, who's my collaborator here in the School of Occupational Therapy, and Tal Mensch-Lifshitz, another wonderful PhD student, and we are working on this project together. In order to cope with the challenges of measurement, we are utilizing what's known as ecological momentary assessment. Ecological momentary assessment, or EMA, allows us to measure what's happening in real life. We send parents a questionnaire through SMS twice a day for 2 weeks. And every time they respond to that message, they're asked to report on the child's RRBs, their own accommodation behavior, and the child's functioning over the last 12 hours. And this all happens on their smartphone. It generates data that looks like this. So we are able to look at each individual child and chart, this is RRBs, across a period of 2 weeks. So you see 24 time points representing the data collected over the course of 2 weeks. We give them Saturdays off. You see that for this specific child, there's a lot of variance within their stereotypic behavior. So there are days that they have more, there are days that they have less. With self-injurious behavior, you see that for the first week and a half, this child displayed no self-injurious behavior. And then clearly something happened and we began to see its presence. In compulsive behavior, you see that there is consistently some expression of compulsive behavior on the part of this child with some variance, but there is never no compulsive behavior. This we are considering as a stepping stone to thinking about support. So the same group is currently building an intervention protocol based on SPACE, which I mentioned, together with Ellie Leibowitz, with the understanding that before any RRBs are considered as intervention targets, there will be a period of EMA data collection for each and every participating family, where they report on RRBs and on family accommodation, allowing us to collect data on that specific child, those specific parents within their broader contexts. We will then be able to sit down with the parents to look at the data together with them, understand the context in which this data is presented, in which these patterns are presented, and tailor this individualized, family accommodation focused, parent based intervention targeting only maladaptive RRBs. I want to express my support again to my students and my collaborators, and to you for your attention. Thank you very much.
Judah, that was fascinating. Thank you very much. And perfect timing. We've got some minutes left over for some questions. Our first question is, and I think the timing of this actually preceded you delving into this topic a little bit. Do accommodating parents have higher levels of anxiety themselves?
So the answer is I don't know, because we don't collect that information. We do look at a couple of other things that we've begun to examine. So we've looked at parent coping strategies, and we are also measuring BAP, the broader autism phenotype traits among parents. So I see Olaf's question. It's an excellent question and a correct question, and it is not one, unfortunately, that I'm able to answer at this point.
Fair enough. So Olaf was busy. He's got a second question for us as well. So could teacher accommodations be written into IEPs, which are individualized education plans, and not be so reactive as in the home environment?
Yeah, so another excellent question. It is possible. I will say that the data that I presented here is actually primarily from children who had not yet been placed in special education settings, because they're coming to us for an initial diagnosis. So they would not have what we, the Israeli equivalent of an IEP yet. But it certainly speaks to a broader question, I think, that Olaf is raising of whether or not teachers may be coming at this from a more professional orientation, and may be accommodating in a more educated and evidence-based way, with consideration of what might be better or less adaptive for the child, while parents are maybe less familiar with educational principles, and also just with a child in a different environment than the classroom.
Yeah. Excellent, excellent. Next question, a bit more clinically inclined here. So Mohammed would be interested to know if there's any research looking at associations between psychotropic medication and family accommodation as it relates to RRBs or anxiety. He mentions that clinically, we see many children whose parents are considering medications to target RRBs, specifically those self-injurious behaviors, but the literature for such is either very minimal or negative.
Yeah, absolutely. So another excellent question, Mohammed. I'm not familiar with any, and I think that the answer, I'm pretty confident when I said that the answer is no. There has been no research looking at this. I will say that I want to sort of place a very large and bold asterisk over this conversation, because our understanding to date of the relationship between family accommodation and RRBs does not lead us to make any clinical recommendations. We know that there is a cross-sectional, very strong association between these structures. I will give you a sneak peek that we've started to look at longitudinal data, and we know that there is an association over time as well. But we firmly believe that we are not sitting on an answer as to how to identify which combinations of accommodation and which RRBs are adaptive or maladaptive. What we are offering is this EME model that basically indicates that in order to consider whether or not there is something adaptive or maladaptive here, we just really need to understand each and every individual child and family. We don't believe that this notion of a book, that this is the way to target RRBs through family accommodation will ever exist. We think that based on the data that we've seen and looked at so far, it will have to be an intervention that is subjective, that is individualized to each child and family, and that it is administered by really skilled and trained clinicians.
Nice. Thank you. Next question. So Claire, thanks you for the interesting talk. And would you be able to articulate a bit more on how family accommodation for anxiety, so the SPACE program you mentioned, differs from the conventional FA? And could you give some examples if you have them on hand?
So first of all, I should say that the situation is slightly the opposite. Like we're the new ones. Family accommodation and anxiety is something that's been researched for many, many years, and there's a tremendous amount of understanding that we've gained as a field in that area. Whereas family accommodation in autism is really not very well understood. There have only been, to the best of my knowledge, 3 or 4 papers published. So we're really at the very beginning of our understanding of that construct. The notion is the same. The concept of accommodation refers to proactive modifications or behavior on the part of the parents that are intended to reduce the stress of the child, which stems from the difference or from the disorder. So in our context, we're looking at stress that stems from the RRBs, and in anxiety or an OCD, we're looking at stress that stems from the anxiety and OCD. Obviously, and this may be what Claire is alluding to, there's overlap, right? And there are going to be specific symptoms or behaviors where we may be unable to distinguish whether this is something that etiologically stems from anxiety or something that is an RRB. I would argue that it might not matter in the end, where it comes from. What matters is our ability to identify whether it's adaptive or maladaptive and then act accordingly. I hope I understood that question correctly.
Hopefully so. If she needs more clarification, we can just type it into the Q&A and we'll follow up. But for now, I'll move over to our next question. So we've got one popping up from Terry Bennett. So Terry's asking, what do you see as a good broadband measure of anxiety in RRBs in autistic kids and youth, or do you use separate questionnaires?
We use separate questionnaires. We don't have a single measure. In our SPACE paper, there's a relatively new measure that was published by Larry Scahill's group called the PRAS ASD, which measures anxiety in autistic children. And there are other anxiety-specific measures that are not specific for autism, but we don't have a measure that looks at both.
Okay. And another question from Terry, just busy typing these in. So do you see some of these principles applying to sensory sensitivity and avoidance as well, as the concept of accommodation or avoidance versus tailoring developmental needs is analogous in many ways?
Okay, so if I understand this correctly, first of all, I will say that when I presented the team that's working on the development of this intervention, so Tal is she's a PhD student, but she's also a very experienced clinician. She's an occupational therapist, so she is making sure that we maintain focus and consideration of sensory sensitivity and avoidance, and that is in our modified version of the SPACE protocol. There's going to be a whole module that is related specifically to that. So I'm not sure that if I spoke to your question, but we definitely believe that these principles should be applied to sensory sensitivity and avoidance. But again, we're super duper cautious before considering anything, objectively maladaptive or adaptive. I think it ends up not being about the specific RRB, but about the context and the interaction between the RRB and the child and the family and the setting.
On that note of speaking about maladaptive versus adaptive, so the next question just popped up. Are there ways of conceptualizing RRBs that separate maladaptive from non-maladaptive RRBs? For example, insistence on sameness factor and repetitive sensory motion factor, or any other subdomain sets you might be aware of?
So to the best of my knowledge, the answer is no. We have a paper that we're working on now that, found that, a couple of specific RRB subtypes associate more with adaptive functioning than other RRB subtypes. But the truth is, I don't pretend that is the answer. I really believe that in this context, group data is not going to be the solution and will not be the stepping stone to supporting children around their RRBs. Obviously, all of this is with the significant exception of self-injurious behavior, which is always and by definition maladaptive. But other than that, I would argue that every symptom that falls under the category of RRBs must be considered within the context in which it exists.
All right. We've got our next question from Stelios. Stelios is asking, are you planning on examining the association between effects of space, parental intervention, and NDBI intervention outcomes, parent and child level?
So great question. The answer is no. So even from conceptualization, the intervention that we're developing, which we're calling space RRBs, is not what we would call a primary intervention. So we're intending to start a pilot study of this intervention this coming summer, hopefully, and we are not recruiting children with an initial diagnosis. We believe that autistic children who are just diagnosed need to receive evidence-based NDBIs, be in appropriate settings, obviously, and receive appropriate support. And this intervention, at least currently, I would say, is secondary or complementary to that, because it really only focuses on the maladaptive RRBs, or will hopefully only focus on the maladaptive RRBs, which I do believe would sort of have a downstream effect of improving social communication and interaction and play, other things that are not necessarily present within the intervention protocol. But that's not what we're targeting. And so initially, I believe every child needs an intervention that targets, their specific areas that they need support in, which in autism obviously largely focuses on criterion A. And a subset of these children, and I will say also, even based on the data that I presented, this notion of intervention is not going to be appropriate for every child, and it's not going to be appropriate for every family. Our assumption, our evidence-based assumption, is that there will be a subset of children and families who will significantly benefit from this intervention. But I certainly wouldn't pair it with, and I wouldn't even administer it initially at the same time as a more sort of fundamental NDBI.
Okay. Fascinating, fascinating. Maybe I will ask sort of a question I had at your hamburger story, Judah. I've heard that story before. So I was struck by, that paper that you mentioned writing with Stelios, I'm assuming some time ago. I like these big picture questions of asking folks if, since the time you conceptualized and published that paper, has something sort of changed in your thinking? Or do you go back and reread that paper and think, yeah, we were on track?
So I like what we wrote. I think I think these ideas make sense. I think it's easy for us to talk about these ideas maybe as academics, and it is maybe more difficult to see the expression of those ideas in clinical practice. But I actually think that there's a lot of value in remembering criterion C and D. When we think about what autism is, and when we think about where difference stops and disability starts. I think these are critical points, and I think they're often overlooked. And so I stand by what Stelios and I said in that paper.
Oh, well, that seems like a nice way to kind of wrap this up, doesn't it? So I will sort of kind of segue into our wrap up now. So I want to thank you very much for giving us your time and, fascinating and informative presentation. And for now, I'll stop our recording and bid everybody a happy day.